Thank you for joining us today at this 10th session of ISSUP Nigeria chapter bi-monthly webinar, tagged ISSUP Nigeria Knowledge Update Series, and the first for this year, 2022. So I say Happy New Year to everyone. We do hope you will join us in our subsequent webinars this year. Today, the United Nations Office on Drugs and Crime, UNODC Nigeria office, will be sharing with us innovative approach to drug demand reduction in Nigeria following COVID-19 pandemic. I want to believe there will be a lot of questions today, so I encourage you to use the chat box to send your questions in the course of the presentation. To moderate this session with me today is the Public Relations Officer of ISSUP Nigeria chapter in the person of Bawo James, though he will join us shortly. Today, the speaker for today is Dr. Akanidomo, KJ Ibanga. Dr. Ibanga holds a PhD in psychology from the University of Birmingham, UK. An MSc in clinical psychology from the University of Benin, and BSc in psychology from the University of Nigeria, Nsukka. He is a fellow of the Nigeria Psychological Association, has over 30 years of work experience in the area of drugs. He has held lecturing and research positions in tertiary institutions in Nigeria and United Kingdom. A senior leader with a record of success in developing innovative and effective policies, resulting in programs and services with sustainable change. He has demonstrated ability to build multi-stakeholder platforms, partnerships, and implement strategies at the local, national, and international levels. From 2014 to date, he is serving as the National Project Officer, Drug Demand Reduction in UNODC, working with a European Union funded project, Response to Drugs and Organized Crime in Nigeria. In this role, he has been instrumental in development of policy documents nationally, successful organizing and cascading training of health and care practitioners at national, state levels on delivering of evidence-based drug treatment services. Highly effective cross-cultural and cross-sectoral communicator with international experience working with government agencies, civil society organizations, academic institutions, and the private sector. He has also demonstrated scientific leadership as evidenced by 90+ publications and presentations across peer-reviewed journals and international congresses. Please join me as I invite Dr. Ibanga to take it up from here. Thank you.
Yeah, thank you. Thank you, Dr. Martin. I hope you can all see my screen. Basically, when we're discussing this topic in terms of UNODC innovative approaches to drug demand reduction in Nigeria following the COVID-19 crisis, my thoughts were basically not so much what UNODC has done, but maybe to give us a picture of what actually is, what has been done, and what needs to be done. So to give us an opportunity to be collectively involved. And so I'll be taking a slightly different approach in discussing this, probably to provide some kind of background to the drug situation in Nigeria and to put it within the context of COVID and how COVID has changed that scene or is likely to change that scene and the needed response. So in 2017, there was a study, a national household study in Nigeria. That study had three components where it studied the household in terms of individuals in the household to see to what extent we would find drug users and what kind of drugs they were using, what pattern of drug use existed. In addition to that, also 250 plus individuals in each state who were assessed to be high-risk drug users. That is, they were either using heroin, cocaine, amphetamine, or injecting, and had used within the past 30 days at least 5 times. So these ones were considered high-risk drug users. This kind of excluded anybody that used cannabis only. And we found out from that research, it did give us, and I think that's the latest research we have that's national, that has given us an idea of the drug use situation in Nigeria. And what the results showed was that we have 14.3% of the population between 16 and 64 years of age that had said that they had used drugs in the previous year. So 14.4% prevalence. Now, to contextualize that, you have to realize that the global average is in that, about that same time, was 5.6%. That means Nigeria had a drug use prevalence of almost 3 times that of the global average. Now, in terms of, I mean, this slide kind of breaks it down for the different drugs and where it was measured or seen as the person using the drugs problematically to the point where he would be considered as being drug dependent. Do note that this wasn't to say that this is a clinical measure of drug dependence, but in terms of the questions asked using the ICD-10 and DSM-3, which is used to determine drug dependency, to a large extent, these ones had fit within that category. So we basically had what you would call overall 1 in every 5 drug users in Nigeria would be considered to be dependent on the drugs. Now, out of that, we had then looked at the high-risk drug users. In terms of high risk, we did define them. What was peculiar about these high-risk drug users, which came to about 376,000 within the country, was that 40% of them actually wanted treatment. 70% knew they had a problem and knew, they could do with help, but 40% were actually desiring to enter into treatment. But again, we'll look at this later to see that even though they desired treatment, many of them did not have access to treatment. And the reasons they gave was prohibitive costs, the stigma associated with being treated for a drug use problem. Treatment wasn't available. There was no information on where to find local treatment. So these were some of the reasons given. Now, in terms of estimates of drug use, projections gathering all the information worldwide has shown that there'll be an increase in drug use by 2030. But interestingly, this increase will come largely from Africa, where we're postulating a 40% increase in the people that will be using drugs. Now, the more people you have using drugs, it also implies that the more people you're likely to have that will have drug use disorder, meaning that you have to have facilities to cater for and treat these people. Now, holding those postulations in mind, you then bring in COVID-19, which came after those postulations. And COVID-19 had its peculiarities. For instance, the fact that it came and brought about changes in terms of availability of jobs, in terms of people being laid off and increased poverty, leading to a lot of conflict, limited opportunities in education. You find out it set up a vicious cycle which would eventually contribute or exacerbate the drug use disorder situation. What that means is that if we're expecting 40% and you add COVID and say, okay, it's a little more than that, to the present situation in the country, it means that we have to, at this point, begin to act very decisively in terms of the efforts that we put into addressing the situation. part of the things, and probably the first line of response, is to enter into prevention. You need to advocate sufficient funding into prevention, particularly in the national post-COVID budget, and to make sure that we accelerate the availability of certain services. What UNODC has done was to then increase and improve the sustainability of the Unplugged Prevention Program. This is a 12-session program that was, through a randomized controlled trial, seen to be very effective in preventing cannabis, alcohol, and tobacco or cigarette smoking among secondary school students. Currently, it's being implemented in 104 colleges, federal government colleges, and UNODC has stepped up to get this to the state schools. So in that line, Kebbi State, Bayelsa State, and Kaduna State are in line to implement this. And it gives us room to say this needs to get to all the states, to all the schools, both private, public, government-run schools. In addition to that, UNODC has an intervention that is for out-of-school use, and this is the Line Up Live Up program, which is a sports-based program, which then can be used to interface or intervene for children that are not in school. And UNODC is currently in the process of rolling this out. It has trained a pool of trainers within the country, so they're training 6 individuals that will be able to train others to, implement this program. Currently, the stage is set for implementing in Borno, Gombe, Ekiti, Kaduna, and Sokoto State. In addition to that, you will remember that during, and largely, not to blame Trump, but largely around that area, there was all this concept about fake news and how much can you trust the information you're getting from different sources. This was complicated, or it showed up again when the COVID pandemic hit, and you had all these conspiracy theories about the pandemic, and many people didn't know exactly what to believe. And so combating false information became paramount in terms of a response. When it came to drug use, what we did find is that the perception of young people between, from 1995 to date had decreased in terms of their perception of cannabis being risky. So many of them currently don't find 40% decrease in finding cannabis as harmful. Whereas you find that the potency of cannabis has actually increased over the years from 4% to 16% in the US. Currently in Nigeria, we state that the THC content of the cannabis plant in Nigeria is quite high. We don't have trends in terms of studies that have kept watch of that over the years, but this is something to keep in mind, as it is it plays a role in terms of the negative or health consequences from a regular use of cannabis. And you can see that led to part of what was a 2020 theme of share the facts on drugs and save lives. Basically, we needed to combat the misinformation surrounding drug use and the stigma that is often associated with that. So that means raising awareness, having comprehensive programs that can evaluate the impact. UNODC has a DPT sensitization program, which it has widely disseminated. It has a set of master trainers within the country that are capable and have been delivering this package, and many human interest stories as a result of that. We also have the drug education for school children. So it's the package that would enable school children have better knowledge in terms of the impact of drugs, and helpfully from that be able to prevent them from experimenting. The other thing we noticed in with the COVID response was that there were changes with respect to the drug trafficking routes. So results or data collected showed that there were larger shipment sizes, there were increased use of private jets to move drugs, increased use of water routes, as well as contactless methods of delivering drugs to end users. What it means by this is that there's a need for different countries and different agencies to share data and to be able to monitor and understand the drug trafficking situation better, because it would have an impact in terms of drug use patterns within the different countries. The other thing we noticed during the COVID response was that a lot of people turned to the internet. Many of us started buying things from the internet, including food. Also, what increased during that time was the use of the internet by people who traffic in drugs or who distribute drugs. And the internet does have different layers, and the layer with the what you call the dark web is or the dark net is a layer that's overlaid with so many networks that is very difficult to identify who is selling what and to who, and therefore drug dealers have softwares and configurations that allow them to use this dark net to be able to deliver drugs to end users. So we have found that over the years that there has been an increase in the use of the internet for drug sales. This, of course, requires very innovative solutions. It requires international cooperation. It requires joint investigation teams that cross different countries and data that crosses national borders. Based on this, part of what UNODC has done and is doing is trying to get these collaborations in place and joint efforts by different teams in the different countries. So these are things, again, that member states within the UN are being supported and given technical assistance in terms of how to set up systems of corporations that would help them share data that would then help them address or respond to peculiarities within their environment. When it comes to people who use drugs, the COVID situation did bring out certain peculiarities that were related to them. When we looked at the data from the US, where they studied 73 million patients in 360 facilities, they found out that the people who use drugs made up only 10% of the sample, but they accounted for 15.6% of those that were diagnosed with COVID-19. Also, that if you had used drugs at any point in time in your life, it just showed you had a higher likelihood that you could contact COVID-19. The other issue was that they were also more likely to experience severe outcomes from COVID-19, and more so when it came to overdose, drug-related overdose. US, for instance, reported the highest number ever in 2020, and there was a 30% increase in that as compared to the data they had in 2019. So there was a 93,000 drug overdoses, and that were estimated to have occurred within that year. In terms of a response, what you needed to then have, having this in mind, is that we needed to, in this situation, make sure that the drug user who's already marginalized, but because of COVID-19 had peculiarities that further marginalizes him and makes it more difficult to access a service, was to look for ways in which we could intervene and make this easier. So part of it was to, one, ensure that if a drug user went for treatment, he too would be seen by a practitioner that, you know, had access to personal protective equipment, therefore protecting both the practitioner and the end user. You find that in many hospitals, when you have limited supply, is usually channeled to what they consider as the most needed areas. And often the drug ward will be one of those that's not thought of. So UNODC, in recognition of this, sent this personal protective equipment to many of the drug treatment facilities across the country. The other thing that it did was also to Dropin Centres that existed and to the Nigerian prison services. The key thing again about the prison services, again, we'll look at it later, is the fact that within the custodial sector, and when people are, as we know, within our prisons are overcrowded, it also means that the likelihood for spread of COVID-19 in those facilities was much higher. We then worked with the government counterparts in terms of looking at how to decongest the custodial centers in terms of either allowing people to serve out their terms at home or other facilities. And currently what we're looking at for the drug user is what you call alternatives to incarceration. So this would be, yes, you've been you've been found to be a drug user, but we need to look for other ways in which you could serve your sentence or be passed through the criminal justice system without necessarily having to go into the custodial center to serve a term. So these are some of the things that UNODC has done. The other thing that we found necessary within this setting to do was to strengthen the state drug control committees. And this is more so because each state's response and access to services was dependent on the knowledge of the government and policymakers within the state that would then allow for, make it easier for someone that has a drug use disorder to access treatment as of when they needed it. And if there were issues or complications, having a state drug control committee makes it easier that someone could be called in within that state to intervene and make that process smoother. The other thing that UNODC is doing in response to the issue of COVID-19 and improving the treatment situation was to build the capacity of existing drug treatment centers and equipping them with facilities that would help them deliver evidence-based treatment services. So this is ongoing in other treatment centers within the country. UNODC is also developing a strategic vision for Africa that has been launched or that has been done. And this response, basically, it's integrated response with the people-centered and human rights-based approach. And the thought is to empower the African societies. Such that it could strengthen societies and institutions at risk for vulnerable groups and then support specific effective responses, particularly to drug trafficking and drug use as well. Now, out of this strategic vision for Africa, UNODC in Nigeria has developed a strategic vision for Nigeria. And that is developed by the country office, and it's to I seem to have that strategic vision is taken from the strategic vision for Africa and then fine-tuned for the Nigerian environment. That brings me to the concluding statements of this presentation, and what I wish to say is that we have a response, and we should be looking at how to make this sustainable, that even though the things we've done in the COVID response, we can sustain it post-COVID. And I think one of the things that I didn't mention was the development of the drug help net, which was very crucial. And this was as a result of the fact that people who use drugs and their family members during the COVID situations were locked in. They did not have access to drugs, and the family members did not, and probably for the first time, would notice that they have somebody in the family who has a drug problem. And in recognition of this, we thought the best thing to do was to set up a way in which family members and drug users can get assistance remotely. So Drug Help Net was set up with a team of volunteers. 129 healthcare practitioners volunteered to participate in the delivery of this service to providers. So we must continue to look for ways to strengthen these services and to allow them to be part of it. In conclusion, I'd like to say that and leave you with this thought that UNODC is doing a lot and will continue to do a lot, but in sharing this, we're hoping that it lights something in you that says that you see a gap in which you can be relevant in making a contribution that would help to address the drug use situation even within your local setting. So thank you. I'll hand you back over to Olivia.
Thank you so much, Dr. Ibanga, for that excellent presentation. Please, participants, remember to send your questions using the chat box. Dr. Ibanga has been able to take us through the drug use situation in Nigeria, more or less as an overview with particular reference to the National Drug Use Survey that was carried out in 2017, which of course indicated or shows that Nigeria is about 3 times global prevalence in terms of substance use. The global prevalence is put at 5.6%. So also highlighted the burden of drug use in Nigeria, among others. And of course, the frightening projection of drug use in Nigeria, in Africa, and of course, including Nigeria in a few years from now, which of course is frightening, I must say. That was even before the COVID-19 pandemic. And with the pandemic, it means that there are needs for urgent steps to be taken to address the situation, because there's no doubt that COVID-19 pandemic has complicated drug use in Africa, particularly.
Martin, apologies to interrupt you. We've lost your audio momentarily. I hope that you can hear me. Martin, can you hear me?
More or less increases or?
Martin, I think we lost your audio for a short period of time there, so that unfortunately we missed the last few minutes of what you said.
So sorry about that. I think there seems to be some kind of network interruption from here. Anyway, I was just trying to at least highlight some of the points made by Dr. Ibanga, which of course included the fact that COVID-19 changed the perception as far as substance use is concerned, especially cannabis use. They talked about the change in trafficking routes, the web nets, the dark nets, which of course was part of which increased during this COVID-19 period. Talks about the different interventions being made by the UNODC, which of course includes the need for global collaboration, to address the challenges, and the establishment of Dropin Centres, the establishment of the drug help net, and building of capacity of personnel in already existing treatment facilities. He also talks about the strengthening of state or local interventions, especially through the state drug control committees. So this is more or less a summary of the presentation by Dr. Ibanga. Sorry for the network issue. Just want to believe that we have some questions now. Let's check what we have. If you're yet to send questions, please use this opportunity to send questions. There's a question here. I don't know if the presenter have the number of UNODC licensed or backed data units in Nigeria. Maybe just location in the geopolitical zones. Just data now, talking about DATR. How many do we have in Nigeria, and where are their locations? Dr. Ibanga, I don't know whether you have a response to that.
I want to hope, and I might be wrong in this, I want to hope that data unit is referring to the treatment wards within the drug treatment wards within the country. We did an early assessment in 2015 in terms of drug treatment facilities in the country. I don't think we had more than 20 then. I think it was 18. The number has changed slightly, and this assessment was just the government facilities, so it did not include civil society organizations, and it did not include private organizations. Currently, what we do have from the last data we were gathering and trying to come up with a directory of treatment facilities within the country, I think we have up to close to 50 facilities that are currently treating people with drug use disorders. Probably what you need to keep in mind when you're thinking of these facilities is that put together, I don't think they are up to 3,000 beds. So that would be optimistic to say that collectively we have 3,000 beds for drug users. And if you follow the treatment of drug use, it means that within a year, if we are very, on the average, have a turnover of users every 3 months, you can logically or technically only treat 12,000 people in a year. But from the data we have from this drug use survey, you have 3,000 people, 3 million people with drug use disorder. And we say if it's 40% of those that actively are seeking treatment, that brings us to 600,000. It just shows you that we're meeting barely 2% of the treatment needs within the country. I hope that answers the question a bit.
Yes, thank you very much, Dr. Ibanga, for that. So, which means well, we don't have enough facilities and facilities to address the need. So you can imagine the percentage. So thank you very much for that. There's another question here which says, since the burden of care is high, what is UNODC doing to support in the area of rehabilitation of persons with substance use disorders in Nigeria? I want to believe these are some of the things you have highlighted. You might still want to add one or two things there.
Okay, so yeah, the burden of care is very heavy. I mean, the data I'm showing you or just highlighted to you is, it's you can only appreciate it if you have a family member that has a drug use problem and you're looking for where to take that family member for treatment. First of all, not every state has a drug treatment facility, and even those in the state, not everybody will recommend for you to use that one. So there are very few to start with, and even the few are only meeting 2% of the needs. And we're saying to you statistically, if we were to say, okay, fine, we can treat 12,000 a year. When you do that calculation, it'll take 100 years to treat just the 600,000 that want treatment. So we don't have treatment facilities that even nips the bud in terms of needs. What UNODC has done, and which we hope is sustainable, is to having supported the Drug Help Net. Now, the Drug Help Net is a telephone-based support service that is there for people who use drugs and have issues and their family members. This would serve a gap in that both men and women will be able to access this service, and it will somehow be available irrespective of where you are within the country. So we are eagerly looking for ways in which this would be a sustainable force that the professionals within the country would maintain and run.
Thank you very much, Akan. So the third question here says, what is UNODC doing in bringing back the services of Dropin Centres in Nigeria, considering the rapid increase? I think that is what you just you highlighted that earlier on. Let me take it with this other question. Are there opportunities to train non-medical personnel to provide any type of support in this area? So you may want to take the two questions at the same time.
Okay, maybe to answer the drop-in center and the non-medical, UNODC has been basically implementing a program that's funded by the European Union. This funding is the largest fund that I presume any country has received from the European Union to address the drug situation in the country. It was tune of 34,000 euros. Now, this project was a 4-year project, but they have been kind to extend it from 2017 to date, and the project, of course, will come to an end. The Dropin Center that were funded by or given grants by UNODC was to show the government and the people of the country that this is possible and the results are immense, and this is something that you should advocate enough to get people to start running centers of this nature that will support people that use them. So since that funding is ending, we are constantly advocating for people that would take up the call to run drop-in centers and have that service available. In that process, we have carried out a series of training. And what we've done in terms of the training is train trainers. So the country has a pool of trainers that are capable of carrying on this training even after the project ends. In that light, non-medical or persons that have a desire to do something within this area can receive that training.
Thank you very much. There is one question here. I'm not really very sure. I think the participant is asking about the consequences of substance use, especially in the university system. That you may want to talk about, but let me take you up on this, which says, what measures and control is UNODC putting in place to curb and control treatment centers that are not operating non-evidence-based treatment interventions?
Yeah, thanks for that question. What are we doing in control? Let me start by saying it. After the assessment of the different treatment centers in the country and the services that were being offered, and knowing the gaps that existed, the UNODC then proceeded to develop the TreatNet training pack, or to bring in that package and to train healthcare professionals. The first thing was to train master trainers, and we had 24 master trainers in the country from selected model treatment centers and training hubs within the country. They then trained trainers each, and those trainers were then supported in carrying out training within their region, within their hospital. So we had large numbers, up to 2,000 collectively plus healthcare practitioners that were trained. Now, there were also training centers that were, or places that were nominated as training hubs within the country. Their responsibility was, they now have trainers within their institution. They had the responsibility of training people within their region who had desires of providing evidence-based drug treatment in any form. And so that is set up within the country. What we have further done within UNODC, and this is has entered into the best practice in terms of internationally, was to set up a quality assurance. So 10 experts were trained within the country, and a toolkit was developed in which they could now assess any treatment service to see how this treatment service meets up with the minimum standards of drug treatment services. And where that service does not meet up with those standards, they had different ways which they can help the service develop a treatment plan that would then push it in the direction of at least providing services that would be minimal in terms of thinking of it as a service. So yes, UNODC is thinking about that and is looking for ways to expand this exercise to cover all centers within the country. But again, this is limited, one, by funding, and two, by the desire of each of the institutions to have this done.
Thank you very much. I think the earlier question is about what UNODC is doing to provide some form of education in tertiary institutions, particularly the university, on the consequences of substance use and so on. But you may want to take that with this other question, even though you don't work with the government, but you may want to say something about it. And it says, I wish to know how the government has contributed in the fight and reduction of drug entry into the country. So what is the government doing to at least reduce the influx of drugs into the country, or drug trafficking, as you may want to put it, even though I know you don't work with the government?
Okay. So I must answer in such a way that it's agreeable. Okay. In terms of the university, let me kind of put it this way. Knowing the consequences of drugs does not stop anybody from using drugs. We have doctors that are using drugs. We have nurses that are using drugs. They know the consequences. We all have habits that we engaging that we personally know they're not good. Our friends have advised us to stop. Our spouses, our children, they've advised us to stop, but we still do it. So even if university students were to know the consequences of drug use, that's not enough to stop them from experimenting with drugs. So we must go a step further in terms of setting systems, laws, institutions in place that actually help to prevent drug use within the society. When you talk of the government and what its contribution has been, I usually answer it in this way. Having been in this field and having worked in a CSO prior to now, in the early 90s, in terms of drug use, one has been able to observe the changes, both in terms of the scenario and in terms of the government's response. And one of the things you would see that within the past couple of years, the government has kind of been actively engaged in trying to find a solution. In 2018, we had the Northern Governor's wife that were together, and they went through a drug prevention and care sensitization training. They had projects that were addressing drug use situation within their states. Sometime after that, you had the Senate president having a roundtable on drugs. Then you had the president having a presidential advisory committee on drugs. I think these are things that show that the government is concerned to the degree that it's able to then follow up with the recommendations of those meetings. You know, we can debate about that and argue about that, but we see over the years that at this present time, the government does seem to show concern and be moving in a direction that it wants to do something about it. If you follow the news more closely in terms of the recent changes in the Nigerian Drug Law Enforcement Agency, you find out that they've been seizing tons and tons of drugs that are coming into the country, which you did not hear of prior to the new chairman being on ground. So you could say that, yes, there has been some improvement in that line. I would say there's a lot of improvement. You have interagency cooperation. Different agencies are now talking to each other, and they're now actively seeing what they can do to work to reduce it. The Federal Ministry of Health has established 2 divisions that are specifically focused on issues that pertain to drug use and abuse and treatment. So yes, the government is doing a lot, I would say. Whether that actually addresses or nips the bud is a different issue. Of course, it's multifaceted, and we all need to do more than we are currently doing for our own drug situation. Thank you.
Okay, thank you, Dr. Ibanga. Let me allow you have a few minutes of break as I respond to, I think, 2 questions that are directed to ISSUP Nigeria chapter. But first, there is this one that is talking about the dark web. I think the question is from a participant from Botswana. Let me clarify that. The dark web was not mentioned as an intervention. It was mentioned as what persons who use drugs or people who use drugs and the traffickers now explore during the COVID-19 pandemic. So it became more or less a source of getting these substances, even though it has been in existence before now. But of course, during the COVID-19 pandemic, it became more patronized, so to say. So it was not mentioned as an intervention, in addressing substance use in Nigeria. Then what is ISSUP doing to address the issue of substance use and even trafficking? That is another question. ISSUP, as an international body, collaborates with other agencies and institutions in the area of drug control, both in the area of law enforcement and drug demand reduction. So we are in partnership or in collaboration with the National Drug Law Enforcement Agency, NDLEA, for example, the Federal Ministry of Health, and even across the state, the different state ministries that are involved in drug-related issues, and the presence of UNODC here today is also part of the collaboration. So it is not what ISSUP is doing as a body, but what level of ISSUP is in collaborating with other institutions to address drug issues generally. At our own level too, we support the capacity of our members, especially those who are members of the national chapter. Not long ago, ISSUP, in collaboration with an education service provider in Nigeria, conducted the UPC training for the members. So that is part of what we are doing. Of course, time will not permit me to mention all the things that we do as ISSUP in Nigeria, but at least this also will at least give an idea of what the level of collaboration with other agencies. So let me look at another question. So I think this is for you now, Dr. Ibanga, as we have a few minutes before we wrap up. Since UNODC can meet only 2% of treatment needs, and there is need for close collaboration between treatment providers and prevention professionals to remedy the situation, what is UNODC doing to train more prevention professionals across the nation? Over to you, Doctor.
Yeah, thank you. First is not UNODC that's meeting only 2% of the need. It's actually how the country is set up, and we need to look at it because it's very sobering. What we're saying is that in this country, we only have 50 treatment facilities that currently engage with people that have drug use disorder. And collectively, those treatment facilities, if I'm optimistic, is not more than 3,000 beds. And I'm saying to you, you have 600,000 people. If you say 20% of them, or you have 3 million people that have drug use disorder, if you say 20% of them want treatment, just 20%, which is usually more than that, that means there's 600,000 that want treatment. Even if they want treatment, you don't have facilities for them to go for the treatment. This is something the citizens of the country and the government of the country has to respond to. UNODC can provide technical assistance. It can show you what the problem is, but the government and the citizens need to respond to the needs of the country. And I think what we've done and what UNODC tries to do is provide that technical assistance where we can get funding, which we search for, is to, again, provide models and show you the models work, and then hand over, hopefully, those models to you as a citizen, to you as the, the government of the country, to then, expand and roll it out to cover the country. So yes, UNODC, we feel how do you call it? We feel the dearth of need for a response to the drug situation, not just as it is, but when you look at the projections, it's even more sobering. So there's a need for us to really think of and take action in terms of responding to what we're seeing in the country and for the country.
Thank you very much, Doctor. I don't know whether you have any last word, because I think this is where we wrap it up. Do you have any last word to say before I conclude?
I think my last words are in this. What I presented was not to talk about UNODC's achievements. It was to show the gaps that exist and the fact that even though we've done so much in quote, there's still so much more that we need to do. And I'm hoping that this presentation in some way provided some light to someone that will say, okay, I can intervene in this way, or I can be of use in providing this kind of service that will help in the situation. Thank you.
Thank you very much, Doctor. Yes, thank you very much, Doctor. You have said it all. You have been able to highlight where we were before now, where we are, and where we need to go. And one of the takeaways is that everyone needs to take ownership of drug use situations or addressing drug use situations. The family needs to take ownership of substance use prevention. The school setting need to take ownership of substance use prevention. The community need to take ownership of substance use prevention. The work setting need to take ownership of substance use prevention. This is part of our song that everyone needs to be involved. It is not a responsibility for UNODC alone, not a responsibility of even the government alone. It is a responsibility for everyone. I want us, from this presentation, there are gaps. The question is, how do we at least address these gaps to make sure that the threat ahead of us, is taken care of, or at least pushed away, not in such a way that definitely will not come. So at this point, I want to once again thank Dr. Ibanga for the excellent presentation, the highlights, and I want to thank the participants from all over all countries across the globe. I want to thank ISSUP Global for all the support, and thank you all for believing in us. We do hope that you will join us again in another session, hopefully by March 2022. Thank you all, and bye for now.